Sorry, I would love to introduce Mr. Kuteya Twaambo, who is a cardiac technologist. He holds a bachelor's degree in cardiac technology. This is a program which is new. I should mention that in Zambia, we don't have these cadres. I stand to be corrected, but as far as I'm aware, they were just having, I think, we don't have these guys more than 5 or so in the country. They are well trained in these procedures, that is cath lab and these other related. They also practice some basic echo. So I'm so comfortable that we'll be having this presentation from an expert who knows what he's doing, somebody who has been trained to do this. So let's pay attention and make sure that we get at least some knowledge on what is going to be presented. That's some house rules. Please, let's make sure we mute our mics as we listen or as we join so that we don't disturb the flow of the presentation. Mr. Kuteya, please, you can go ahead and the floor is yours. Thank you.
Thank you very much, Mr. Mlenga, for that. Good evening, everyone. So today I will be running through or just discussing about the clinical significance of a left bundle branch block. And we can begin now. Okay, so to start with, we will look at briefly the table of contents here, just showing the topics that I will be touching specifically. So first of all, we're going to go through the conduction system. We're going to look at the normal conduction pathway, how it works, and then we'll get to our main topic, which is bundle branch blocks. In specific, we will be looking at left bundle branch blocks. We will also look further into the ECG presentation of such blocks, as well as the electrophysiology. And after that, we will get to the echo presentation, which I'm sure is what most of you are eager to find out here today. So we will begin now. So coming to the conduction system, the heart has two main types of cells. First of all, we have the conduction cells or the conducting cells, which are responsible for generation and propagation of electrical impulses. Then after, we also have contractile cells, which are responsible for contracting, following the receipt of electrical impulses. The contractile cells can also propagate and sometimes also generate electrical impulses. But when they do so, we call them ectopic generations because they're not coming from normal or point of origin, as we will see later on in this presentation. So the conduction system of the heart basically is the system that controls cardiac contraction. And this is responsible for the contraction and relaxation of the heart, as we will see later on in this. So right now we're going to go ahead and look at the structure of this conduction system. So in figure 1B, as we can see here, the conduction system is made up of, first of all, the sinoatrial node or the SA node. This part of the conduction system is the heart pacemaker. Okay, it's responsible for initiating the impulses that will travel through this system. It is a group of cells which is found high up in the right atrium, as we can see in figure 1A. It is located in the high up in the right atrium, and close to its junction is the superior vena cava, as we can see there. The SA node is also responsible for spontaneously generating these impulses which will travel through the conduction system, which is why it's called the heart's pacemaker. It sets the tone for how fast exactly the beats will be traveling, or the impulses will be traveling through this system. Secondly, we have the AV node, or the atrioventricular node, which is situated at the AV septum, just above the coronary sinus there, as we can see in figure 1A. It is responsible for receiving these electrical impulses from the atria, and after that transmits them through the ventricles. It is also responsible for slowing down the speed of the impulse that travels through that comes from the SA node through the AV node. So when the impulse starts from the SA node, it's at a certain speed. As it comes down to the AV node is responsible for reducing that speed. As we will see later on, we will discuss this further in detail. After that, we have the bundle of His, which will receive input from the AV node, and the bundle of His itself branches into the left and right bundle branches, which travel down the IV septum and terminate as Purkinje fibers, which is the last part of this conduction system. Each Purkinje fiber would terminate in the subendocardium. As you can see here in figure 1A, the Purkinje fibers will terminate in the subendocardium of each ventricle, right and left, respectively. And they transmit the wave of electricity to the ventricular myocardium. And this wave of electricity is what results in ventricular contraction, okay? So now we will look at the normal conduction pathway and just try to see how exactly the impulse will make its way through the heart, passing through all these parts of the conduction system. How does a normal conduction pathway look like? How does the impulse move from the beginning up until the end when contraction is done? So first of all, the impulse will be set from the SA node. Okay, so the SA node in normal cardiac conduction is the one that generates the impulse. Before, I did say that other parts of the conduction system, other parts of the heart are able to generate these impulses, but then we call them ectopic type of generations because they are not really where the impulse is supposed to begin from under normal conditions. So the SA node is the one that generates the electrical impulse under normal conditions. And this impulse spreads across the atria, okay? And this primarily occurs via cell-to-cell conduction. The velocity of the impulse in the atria is about 0.5 meters per second. And when this impulse is released from the SA node as it passes through the atria, a phenomenon known as depolarization occurs. Okay, so as the impulse passes through the the atria, the depolarization of this atria or these chambers will occur, and this will cause them to contract by a process known as excitation contraction coupling. After this, the impulse will move down from the atria up until it reaches the AV node. So the AV node receives and delays the impulse, as I stated earlier. The electrical impulse reaches the AV node, whose main function is to delay it by about 10% before it relays this impulse to the bundle of His. This delay occurs in order to allow sufficient time to complete this atrial depolarization that is occurring as the impulse travels through the atria. Okay, so this contraction happens before ventricular depolarization and contraction can occur. So first of all, the atria will contract before the ventricles do. This is why the impulse has to be delayed as it reaches the AV node. After the AV node, the impulse travels to the bundle of His, or the His bundle. And at this level, the electrical impulse will travel equally down the left and right bundle branches. It will travel equally at the same time down these branches, respectively, left and right. And the activation of the septum as it travels down these bundle branches will occur from left to right. It is important to note this, that the septum will activate from left to right under normal circumstances. And the speed of the impulse as it travels down this, the his bundle will be about 2 meters per second. Recall that as it was coming down from the atria, it was at 0.5 meters per second, and the AV will delay it. So this means that as the impulse travels from the AV node down the bundle of his, it is sped up. It goes all the way up to 2 meters per second before it goes to the Purkinje fibers, which will stimulate the ventricular myocardium. So coming to the Purkinje fibers, they stimulate the ventricular myocardium, which will result in ventricular contraction. And then after that ventricular contraction, this whole process repeats itself. Normally this occurs 60 to 100 times under normal conditions, normal circumstances. And the speed of the impulse will also be increased the speed of the impulse will also be increased as it travels through the ventricles. So it starts off with a slow speed in the atria, comes down to the AV node, which delays it a little bit before it comes down to the bundle branches, where it is sped up, and then it goes all the way to the Purkinje fibers where it is sped up some more, which means Purkinje fibers have the highest velocity when we're talking about impulse conduction. I hope we are all clear on this part of the conduction pathway. So now we will look at a bundle branch block, specifically discussing what it is and how it results. So the conduction system is a pathway. Blockage in the pathway of this conduction system will result in the impulse trying to find an alternate pathway. But the blockage in in a bundle branch results in a block in the specific bundle branch. So if there's a blockage in the left bundle branch, we'll have a left bundle branch block. If there's a blockage in the right bundle branch, it will result in a right bundle branch block. And just to repeat what I said earlier, in normal cardiac conduction, the impulse will travel down equally through the left and right bundle branches, and the septum will activate from left to right. It's important to note that they will travel down equally, and the septum will be activated from left to right. This left to right activation of the septum results in small Q waves in the lateral leads of an ECG tracing. We will look at that shortly, and you will be more clear about what exactly it is that I mean. Okay. Coming down to the causes of left bundle branch block, it is important to note that a left bundle branch block specifically does not occur without an organ disease. It usually is attached or is accompanied by organ disease, which is what we are seeing here when we look at some of the etiologies of a left bundle branch block. We have congenital heart disease, dilated cardiomyopathy, a heart attack, or myocardial infarction in other terms, heart disease, and so on and so forth. So some of these etiologies will just increase the risk of developing a left bundle branch block. Meanwhile, others will cause damage to the conduction system, resulting in a left bundle branch block. So they bring about this abnormality in different ways. Some will increase the risk, while others will result in will cause damage to the conduction system, which will result in a left bundle branch block. Some of these that increase the risk will be dilated cardiomyopathies. We will also see this in heart failure conditions as well as coronary artery disease. Okay, and some of these will affect the conduction system directly and affect its structure, thereby resulting in the blockage of the left bundle branch, which causes certain symptoms in the patient after they come. So after we have looked at the etiologies here, we will go further and now discuss the ECG presentation. Before we look at an ECG that is showing a left bundle branch block, we should first understand what a normal ECG will look like in a particular individual. So this is an ECG that I took myself, where we are working from. The patient information has been covered just to protect them. So here we see what we're looking at right now is a normal ECG. Okay, a normal ECG has certain characteristics that it should follow for it to be termed as normal. If we are not seeing any abnormalities, it means that the individual has a regular rhythm at a rate of 60 to 100 beats per minute, as we know. Above that, it will be tachycardia. Below that, it will be termed as bradycardia. Otherwise, in children, it's normal to, in pediatric cases, it's normal to see a heart rate of above 100 in a normal ECG. Second to that, we will see that each QRS complex, which is the sharp wave that we are seeing at the beginning here. Here, if we look at lead 2, we can see these sharp waves that are at the top here, and these are called QRS waves. And in a normal individual, each QRS complex has the same distance between one and the other. Just eyeballing it from this point here, we can see that the distance between each tip, if we can see here in lead 2, which is where I focused right now, we can see that the distance between each tips is seemingly the same. So after that, we also term a normal ECG if the P wave axis is upright in leads 1, 2, and inverted in 8. This means that the P wave should be upright in leads 1, 2, and it's inverted in AVR. In this ECG, we cannot see it very prominently or very clearly. The P wave is what I'm talking about right now. We cannot see the P wave very prominently or very clearly. But if you look before the QRS complex here, we are able to see just a slight hump just before the QRS complex. That's the P wave I'm talking about. So each P wave is upright in all the leads except in lead AVR, where we're seeing that this hump is kind of inverted. Just before the QRS complex, you can see that this hump is kind of inverted. This is some of the criteria that we follow to determine if an ECG is normal or not. Another thing that we will see in normal ECGs is that the PR interval, which is the interval from the beginning of the P wave to the end of the QRS complex, it is constant. So this interval is constant in normal ECGs. As I said before, the PR interval will be the interval between the beginning of the P wave just as the hump before the QRS begins, and up to the end of this QRS complex. Yeah, so this interval is the same in all of the leads, and it remains constant throughout the leads, as we are seeing here. Also, it is important to note that the QRS complex will be less than 100 milliseconds wide. As we can see, these complexes are not really as wide as they would be in cases of bundle branch blocks, as we will see later. So they are very narrow and straight to the point. On an ECG graph, a small square will be 1 millisecond, and the large square itself will be 10 milliseconds. So as we can see here, this QRS complex is less than the 100 milliseconds in terms of its width. And this phenomenon, unless it's coexistent with IV conduction delay, is termed normal. So sometimes there's a delay in the conduction of the there's a delay in the conduction of the impulse as it's traveling through the ventricles, and this will cause the QRS complex to become a bit wider, but in this case, it is termed normal unless it's coexistent with that delay. So to term an ECG as a normal ECG, it's supposed to have all these different criteria that I have talked about. First of all, the rhythm has to be between 60 to 100 beats per minute. Each QRS complex should be followed by a P wave, and every normal P wave axis should be upright in leads 1, 2, and inverted in AVR. The PR interval will also remain constant throughout these complexes, and the QRS complex will be less than 100 milliseconds wide. If everybody is clear on this, I will continue to the next slide. Another thing that we need to look at before we get to what an ECG presentation of a left bundle branch will look like is lead grouping. So specific parts of an ECG are in the same group, as we term them. So in on an ECG, we have 4 main groups. So we have the lateral part, the inferior part, septal part, and the anterior. So basically what this means is that what go our numbers here. We have lead 1, 2, 3, AVR, AVL, AVF, and then we also have our chest leads, which is V1 to V6. So basically what we're talking about here is that some of these leads are grouped into specific categories depending on how exactly they pick up their impulse, they pick up their signal from the heart. So basically we have 4 groups, as I said before, and lead 1 and AVL will be our high lateral groups. Okay, this will look at the heart from a lateral point of view, but a high lateral point of view. We can also see that our V5 and V6 will look at it from the lateral view. So the difference between these two is that 1 and AVL will look at it from a high lateral point of view, meanwhile V5 and V6 will look at it from a lower lateral point of view. We also have leads that look at it from an inferior type point of view, which is our leads 2, lead 3, and lead AVF. We also have V1 and V2, which will look at the septum. We have V3 and V4, which are anterior leads, so they'll look at the heart from, or they pick up the signal from an anterior point of view. If everybody is Hello? Can you hear me?
Yes. I can hear you from here, but you were
Okay,
going slow, but we can hear you. You
Yes,
can go
we
ahead,
can
please.
hear.
okay,
Yes, we
sorry.
can.
I think I lost my screen. Are you able to see my screen from there?
No, you can share again. I can't see.
Okay. Just give me a minute.
No problem, please.
Okay, are we able to see the screen now?
Yes, we are there.
Okay, so we'll quickly dive into where we left off. Yes, so I was talking about the blood supply of these parts of the ECG. So in addition to the grouping, we also have specific arteries or coronary arteries that will supply these parts of the the leads, basically. When I say this, I mean that's the point, the portion of the heart which the coronary arteries will supply the blood to the heart with. So when we're talking about the high lateral leads, by the circumflex artery. We all know, most of us know that the two main branches of the left coronary. Hello.
Sorry, friends, we seem to be having network challenge. There with the presenter, I think there must be a challenge with network. Mr. Kuteya, are you there?
Yes, I'm here. I seem to be losing my
Yes.
my presentation screen, but when it comes to the connection to the group itself, I'm still
Okay.
connected.
Okay.
Yeah, apologies. Are you able to see the screen now?
Yes, we can see it.
So quickly diving back in. So the high lateral leads will be supplied by the circumflex artery, as well as the lower lateral leads. Our inferior part will be supplied by the RCA, or the right coronary artery. Meanwhile, the LED only supplies to the anterior septal part, which means the septal and the anterior part will be supplied by the LED itself. Okay, so now that we have the general idea of a normal ECG or what it comprises of, we will now quickly go into our main topic for today, which is a left bundle branch. How does a left bundle branch present itself on an ECG? What do we expect to see? What are the differences of left bundle branch ECG from a normal type of ECG? What do we expect to see? So basically, in left bundle branch ECG, we can appreciate a QRS duration of greater than 120 milliseconds. Remember, I said before that the normal ECG will have a QRS complex, which will be less than 100 milliseconds, which it basically entails two small squares on the ECG, as we saw before. What else do we see in a left bundle branch block ECG? We will see a dominant S wave in V1. We will also see a broad or monophasic, as we call it, or M-shaped R wave in the lateral leads of the ECG, the high lateral as well as the lower lateral leads. That's lead 1, AVL, lead V5 and V6. We will see an M-shaped or a monophasic type of R wave. When I talk about the R wave in here as cardiac technologists, we talk about the entire QRS complex, but the positive deflection of this QRS complex is what we're talking about, the R wave. So up there at the tip, instead of it being a sharp pinpointed type of wave as we saw before, it's going to be monophasic or M-shaped in left bundle branch block, as we will see just in a moment. What else do we see in the left bundle branch block ECG? We will see the absence of Q waves in the lateral leads, as well as a prolonged R wave peak time. If the QRS complex is wide, it means that it takes more time for it to reach the R, which is the tip part of the QRS complex. It will take more time to reach that place before it comes back down. Other related criteria to diagnose or be sure about the left bundle branch block will be that we will see some axis deviation, in particular left axis deviation. We'll also see poor R wave progression in the precordial leads, which are basically our leads from V1 to V6, as well as a phenomenon called appropriate discordance, which is something that I will touch in a bit here. So let's look at some of our left bundle branch blocked ECGs. So how would the ECG present? If we recall what a normal ECG looks like, just eyeballing this ECG here, we are able to tell that it is something quite different. Okay, as well as we can see some criteria that we talked about in the previous slide here. I would love for some of you to just take note of this criteria here, because it is what we will be running through as we discuss some of the examples of ECGs that we that involve left bundle branch block. Okay, if everyone has taken note of this, I will gladly move on to the next slide. So criteria number 1 for a left bundle branch block, as we saw in the previous slide, was a QRS duration of greater than 120 milliseconds. Okay. In this ECG, we can see that our wave, our QRS complex is quite wide in our leads here. We can see from lead number 1, 2, 3, all the way up to our V6 here, that our QRS complex isn't really what it looked like in our normal ECG tracing. Here we are able to appreciate a QRS duration which is greater than 2 small squares. We can't really make out the small squares because of the size of the, can't really zoom in too much, but we are able to see that the QRS is quite wide from what it was in the normal ECG. Okay, another important factor to note, criteria to diagnose the left bundle branch block, is a dominant S wave or a dominant depression. So our S wave will be the negative deflection of the waves in our V1. So this negative deflection that we are able to see here in V1, a deep and dominant S wave, we call it in lead number V1. We are able to see it here. Another thing will be monophasic or M-shaped R wave in our lateral leads, which we can appreciate here in leads 1 and AVL. And I think we can see it in our V5 as well. If we can see this positive narrow deflection after our V5, that is a premature ventricular complex, which is a topic for another day, really. But we are able to see that the QRS complex before that is appearing quite notched at the top there. That's a monophasic R wave, as we put it. So putting all of this criteria together, we are getting closer to diagnosing this patient with left bundle branch block. Another criteria that we looked at in the previous slide was an absence of the Q waves in the lateral leads. And as we can see here, there is no negative deflection at the beginning of the QRS complexes, as we saw in our ECG, our normal ECG wave, our normal ECG in this slide here. If we look at lead number 1 in AVL, we're able to see some negative deflection at the beginning of that QRS complex. We can appreciate also that V1's S wave, which is a negative deflection after the positive one, is not very dominant. We have a positive R wave before the negative deflection into the negative deflection, which is what we call our S wave. We can also appreciate a narrow QRS complex in the normal ECG here. We are able to see that the QRS complex itself is not wide, and also that it's not monophasic. So going back to our first example of a left bundle branch here, we are able to see this criteria, especially when we come down to our rhythm strip down here, our lead 2. We're able to appreciate the M-shaped QRS complex a lot more clearly in this view, in this lead. Sorry, in this lead, we're able to appreciate monophasic or M-shaped QRS complex. So putting all of this criteria together, we diagnosed this 74-year-old male patient who came into the hospital, and we're able to diagnose him with a left bundle branch block. Another example of a left bundle branch block here, we are able to see some of the criteria that I mentioned: a dominant S wave in V1, a wide QRS complex as we see in most of our leads here. We are also able to appreciate a monophasic or M-shaped R wave in our lateral leads. We can see our monophasic or M-shaped, something in V5 and V6 here. We're able to see that it's wide and quite notched at the top, not quite sharp as it would appear in a normal patient. Another thing that we're able to see here is the absence of Q waves. There is no negative deflection at the beginning. No Q waves are seen in this ECG tracing. We are also able to notice how it takes a longer time for the QRS complex to reach its peak R wave time. Yeah, so we took this ECG tracing in a 84-year-old female who came to the hospital as well. looking at this ECG and those criteria that I shared before, we're able to diagnose this patient with left bundle branch block. Moving on to our third example of the night. Another classic representation of a left bundle branch block when we come to ECGs. Our dominant S wave in V1 is seen here. We cannot quite make out our monophasic or M-shaped R wave, but we can see that the QRS complex here is definitely wider than it is in a normal ECG. Sometimes the criteria will present itself in other leads here, as we are able to see in lead AVL. So putting all of these criteria together, experienced person will be able to diagnose this patient with a left bundle branch block. We can see all of those criteria that I shared before in this patient as well. This is another case of left bundle branch block, and we can see and appreciate the similarities in these ECGs. They were taken for different patients, but they are coming to look very, very similar. We can see the criteria of a left bundle branch block. Dominant S wave in V1. We also have our monophasic or M-shaped R wave, lead 1, AVL, V5, and V6. We are able to appreciate this. So in the beginning, I also talked about a phenomenon known as appropriate discordance, if we are able to recall some of the related criteria when it comes to diagnosing a left bundle branch block here. We saw the third point under the related criteria was appropriate discordance. Now, what do I mean when I say appropriate discordance? To explain that, let me quickly just rush to left bundle branch block ECG here. Okay, so appropriate discordance basically refers to the fact that an abnormal depolarization should be followed by an abnormal repolarization. If the depolarization was abnormal, the repolarization will also be abnormal. This will appear as discordant to the preceding QRS complex. What do I mean when I say this? It means that a tau deflection or a tau QRS complex will often be associated with an SD segment or the following wave after our QRS complex will be in the opposite direction of the QRS complex. We're able to see in this example here that everywhere we have a tau QRS complex going in one direction, the wave after that one that follows will be going in the opposite direction as well. Comparing this to our normal ECG, we're able to see that all of the waves here are quite positive in all of the leads except AVR and V1. Now let's look at our left bundle branch blocked ECG here. We're able to see that there's appropriate discordance. Where a QRS complex goes in one direction, the following wave will go in the other direction. Putting all of these criteria together will help us diagnose certain individuals with left bundle branch blocks, basically. Okay, so now that we all understand and we have all heard about what exactly a left bundle branch block will look like in a left bundle branch, a left bundle branch block will look like on an ECG, we will move on to look at how exactly it presents itself when we are looking at the echocardiography. Okay, so basically in echo, a left bundle branch block will produce a wall motion abnormality. Okay, this wall motion abnormality will mimic some criteria of ischemic wall motion abnormality and ischemic wall motion abnormality of the IV septum. And this wall motion abnormality might be present with or without structural heart disease. Therefore, it's important that we carefully evaluate the wall motion in the presence of left bundle branch blocks, because this will allow us to identify signs which will help us to better differentiate between ischemic wall motion abnormality and left bundle branch block wall motion abnormality. So we should also recall that in systole, we have, for those of us that do echo, we all know that in systole, we have a continuous motion of the intraventricular septum, which moves towards the center of the left ventricle as it is in contraction. And in diastole, it will move backwards. There will be a backward motion, which will be moving away from the left ventricle. But in a left bundle branch block, we will see that there is paradoxical movement. There is movement that is contrary to what I just explained here. And this paradoxical movement occurs in such a way that during early systole, the movement of the intraventricular septum will be moving towards the center of the left ventricle. But before going to diastole, in the end, in late systole, this IVS will move away from the IV from the left ventricle in late systole, and basically it looks like a small jerk movement of the intraventricular septum. And in addition to this, there's also complete dyskinesia of the septum. Okay. It is also important to note that in some subjects, this paradoxical movement is so transient. Okay, it's so quick that it appears as a small jerk inward and outward of the left ventricle. It appears as a small jerk movement. I will show you what that looks like in the next slide. So in left bundle branch block cases, this paradoxical movement will appear as a transient small jerk movement, while in other cases it will be completely dyskinetic. Okay, but the most crucial factor for determining whether the septum is viable or not will be the thickness of the wall. And this thickness will also disqualify a septum that is functional but still akinetic. So what exactly do I mean when I say this? Before before we continue here, um, allow me to pull up what exactly this will look like in a case of left bundle branch block quickly. Sorry, just give me a minute. Pulling it up quickly.
Okay, no problem.
Okay, so in left bundle branch, in a normal, before we get to that, in a normal heart, we are able to appreciate the following when we take an M mode at the tips of the mitral valve leaflets. This is what we see in a normal in a normal myocardium. It's normal contraction and relaxation of the heart. So we can see that there are crests and troughs of the IVS motion here. You can see it thickening in our top image there in contraction, as well as slimming up in our relaxation phase. Sorry, see it relaxing later on. But in a left bundle branch block will appear like this and is quite limited and take an M mode in echo. But in the case of left bundle branch block, the movement of the IVS is very limited. As I stated before, there is paradoxical movement of this intraventricular septum. This paradoxical movement will cause the tracing of M modes to come out in this way, such that the IVS itself does not relax and contract properly. We are also able to appreciate this. We're also able to appreciate this in the M mode here. So it's imperative that we record M mode in all of our general echo procedures. Okay, we always record an M mode in the parasternal long axis view, which is the view that we are looking at right now here. Okay, and as we can see here, we are able to see that of the septum is quite limited as it was in our initial normal contraction and relaxation here, as we are able to see. But what else do we see when we take an M mode of the echo? We are able to appreciate beaking of the a beak-like projection of the IVS is beaking, which is shown basically here by the red arrows here. So there's this beaking is a result of that paradoxical movement. Okay, the beak on the M mode tracing will be as a result of the quick jerk-like movement of the IVS towards the center and away from the center of the left ventricle, as is seen in the early and late stages of systole and M mode. So that itself will produce this beaking-like looking structure when we look at the motion of the IVS under an M mode scan. So here we are able to see two things basically to diagnose left bundle branch block, or to see or to differential diagnosis of a left bundle branch block in a patient. We are able to see that there is limited motion of the IVS. This image obviously is slowed down just to show us for sure what is going on. But we are also able to notice our beaking in here. I'm sure all of us are able to see as it's moving, as the blue line is moving from left to right here, that there is beaking at the top, which is showing us or pointing towards the direction of left bundle branch block under echo circumstances. And basically these two phenomena, which is limited septal motional paradoxical movement of the IVS, as well as beaking, is the main criteria that we use to determine left bundle branch block in the case of echo. What else are we going to see? We're going to see a phenomenon known as temporal dysynchrony. What this means is that some of the left ventricle segments contract, and then later on, some of the other segments will relax. Okay, there's a dysynchrony of how the left ventricle itself is relaxing and contracting. We can make that out from when we look at our posterior wall of the left ventricle here, in a normal cardiac muscle, in a normal heart, we're able to appreciate that at the bottom here, as we can see, that the posterior wall will contract and relax in synchrony with the phases of the contraction and relaxation as compared to in our left bundle branch block here, where we're not really able to see it contracting and relaxing properly. And therefore, we are able to further look or think about the diagnosis of left bundle branch block in a certain particular individual. So to conclude, we have 5 main echo criteria to determine that there is wall motion abnormality due to left bundle branch block. The first thing that we will see is an early systolic beaking of the intraventricular septum, followed by a transient or prolonged paradoxical motion. Another thing that we will notice is that the thickness of the IVS or the intraventricular septum is preserved, that we do not expect a thickened IVS in such a condition. We will also notice that the wall motion abnormality will be restricted to the basal and mid segments of the IVS. It doesn't really extend to apical segments. Or another thing that we will see is temporal desynchrony, as I just explained. And after that, we will see that there is no area of wall thinning. The integrity of the wall will remain as thick as it was in the normal myocardium. There is no thinning of the wall, the posterior wall of the left ventricle. And these are the 5 main criteria, as well as some other criteria, I'm sure, which will vary from sonographer to sonographer, but mainly these are the 5 echo criteria that we'll look at to try and diagnose this left bundle branch block. And that concludes my presentation for this evening about left bundle branch block. Here you will find some of the references or suggested reading articles which will talk more about exactly what it is that I was explaining in this presentation today. I hope we have all been impacted with a certain amount of knowledge out of all of this presentation. And that's it from me. Thank you.
Excellent presentation. Thank you so much, Mr. Kuteya. We are so grateful for your presentation. You all agree with me when I first said one cannot underrate the place of ECG in cardiology as an essential diagnostic tool. You realize that management and follow-ups and even collating of cases becomes very crucial when you do an ECG. We sometimes underrate the power of ECG, but I think you can see just from the glimpse of what has been presented that there's quite a number of things we need to look at. And I know a lot of us, we may not have grasped the principles and whatever has been explained here. It simply shows that we need specialization and we need to respect people's specialization so that we can work together as a team. So thank you so much once more. Quite a number of issues has come out, especially for those who are doing echo. Even for those who are not doing echo, I think we've picked some few things that can really help people to and even integrate your findings. So thank you so much once more. At this juncture, I'll invite questions, clarifications, and contributions. So the floor is open for questions and contributions, audience. Thank you so much.